So my name is Samantha Figueroa. I'm with the Downers Grove Junior Women's Club, and I am so lucky and fortunate to be with some superstars from the West Suburban Women's Health, Dr. Porter, Dr. Malone, and Dr. Rodriguez. Hello, ladies.
Hi.
All right, so would you mind just going and giving a wave as to who's who so our audience knows?
Sure, I'm Dr. Katrina Porter.
I'm Dr. Sophia Rodriguez.
And I'm Dr. Lindsay Malone.
Well, it's so nice to have you with us today. We are talking about a very important topic. As you can see, we're rocking our pink. October is Breast Cancer Awareness Month, and we are so happy to have you talk about a very important topic so we can share this with our audience and our membership. And so we'd like to take the next time or the next few minutes and really roll up our sleeves, get into what we need to know about breast cancer. So first and foremost, give us an overview, if you wouldn't mind, about breast cancer in general, and what is it, and what's the latest on the research front?
Sure. So breast cancer is of course a cancer or a malignancy of the tissue of the breast, often involving either the glands or the ducts of the breast tissue. It's the most commonly diagnosed cancer in women in the United States, and one of the leading cancer causes of cancer death for women in the United States. It's very important to talk about because it's in our lifetime, a woman has about a 12% risk overall of developing a breast cancer, and with a lot of screening techniques and things like that we'll hopefully get a chance to talk about here today as well. It's something that can be that can be detected and help improve prognosis for women. So to say thank you for having us, because we do agree that this is a very important topic for us to be talking about, and Breast Cancer Awareness Month gives us a chance to do that. So, over the last 50 years, the research that's been done and research that's ongoing has definitely led to an improvement in the treatments and the outcome and prognosis for patients diagnosed with breast cancer. Survivability of breast cancer has improved dramatically in the last several years. So, so we're excited to be here and get a chance to talk more about it.
It's so, I think, important to hear that last part that you said, where survivability has dramatically increased over the years. So can we talk a little bit about who is particularly maybe at a higher risk for breast cancer, and then are there specific risk factors that people need to be aware of, or maybe make it more on your radar, or is it really something that doesn't discriminate? So what are we looking at here? Because it sounds a little scary. So what are the key factors that we need to know?
Okay. So the key factors and things that you would want to consider. So looking at risk of breast cancer is certainly something that we address at annual exams as well. And we're talking through things like family history, medication, your own medical history. So things that are in specific risk factors that have been associated with breast cancer have been family history of breast cancer. Also, breast cancers can also have associations with ovarian, as well as other sort of ovarian syndrome associated cancers, which would include prostate and pancreatic cancer as well. If there was a family member that potentially had a known mutation in the genes, as well as patients who've had prior breast abnormalities and biopsies that have been shown to be abnormal, potentially precancerous. Patients who are also at risk are patients who have had early menarche, which means that they started their periods fairly early in life, and then also very late menopause. So women that menopause much later, it's just that we think that you've been exposed to the hormones, estrogen and progesterone, over a period of time for a longer period of time in your lifetime. There's also associations with menopausal hormone therapy with estrogen and progesterone. Women who have not breastfed, age is certainly a risk factor. There are some ethnicities that can be associated with some breast and hereditary breast and ovarian syndrome associated cancers, like the BRCA gene. Body mass index is that high, being like obesity is a potential risk factor, smoking, dense breasts on mammograms. So sometimes some patients have tissue that's a little bit harder to see through, and that can put you at risk of having breast cancer as well. And then what we have known, just as an FYI, is just that women that have ever had exposures to birth control do not carry an increased risk of breast cancer, because that's a very common question that we have as well. But those things are all things that we address at our annual exams to try to determine who potentially meets criteria to have testing done to look for those sort of family syndromes, but also give us an idea of how we should screen them too.
That's so helpful to know the risk factors. But as somebody I just turned 40, it's totally on my radar right now. What are some preventative things that you could advise to the audience to try and just take better care of ourselves, specifically as it relates to breast cancer too?
I think one of the best things that you can do is go to your annual exams. At your annual exam, your doctor is going to talk to you about what you need to start doing. And because you have just turned 40, for you specifically, that would be getting a screening mammogram this year. Other things that you can do to help reduce your risk of breast cancer, we do know that high consumption of alcohol and smoking and poor diet can increase your risk of breast cancer. So those are some things as well.
That's so helpful to know. Now, can we talk about self-examinations? Because I know that that's a really important thing. From the patient side, it can be perplexing, a little confusing. Breasts can be lumpy. You're hormonal throughout the month. They can change. What is the difference between like a dangerous lump or normal lumpy breast tissue, or what exactly should we be feeling for?
Sure. So one important distinction to make is that historically we used to talk about a lot breast self-exams, so much so that there used to be commercials to remind us to do your monthly self-breast exam. What we found actually with doing kind of a scheduled monthly breast exam is that it doesn't necessarily improve the diagnosis of breast cancers, and in fact it can lead to extra testing, extra imaging, even extra procedures or biopsies without increasing the rate of detection. So we've kind of shifted over the last several years away from talking about scheduled breast self-exams, and we now use the term breast self-awareness. And the idea with that is that we aren't expecting you or anyone in the general public to be an expert on breast exam. That's not the goal. The idea is that you know your own breasts, and so it's about being familiar with what your breast tissue is like, what your normal tissue feels like, finding one specific time a month if you are going to do an exam, rather than, like you mentioned, several times throughout a cycle where things can certainly change. But to be aware of what your tissue feels like, what your normal is. The idea is that you would recognize if there were any changes, any new findings, new lumps, any rashes on the skin, nipple changes, things like that. Because it's not your job to distinguish between small little glands and breast tissue that does certainly feel lumpy. I think one general rule of thumb is that anything that's hard like a rock or a pebble is probably something to be worried about. Anything softer or squishier, more like a gummy bear or jelly bean consistency, is probably not. But the key is that a change is a change. So if something is new for you, it is time to escalate that and bring that up with your doctor and schedule an appointment so that can be evaluated. If people are like, well, I don't know what my normal is, I think a great time to get to know your breast tissue is right after you've had an exam. So if you come into the office and see Dr. Rodriguez, for example, she will do a breast exam, and if she says you have normal breasts at home, then maybe now is a good time to get to know your breast tissue, know what your normal feels like, and that's kind of your barometer for when anything would change. So this idea of breast self-awareness gives us the opportunity to recognize changes in your breast tissue without putting the stress and the worry of diligently doing a monthly exam.
That's so helpful to hear, because it is intimidating as a patient trying to, be aware of what you need to try and be aware of. Now, when you're trying to do that region, are you supposed to include like armpit area as well? Is that kind of like what we're thinking? It's like just make a rectangle area on each side. And are we supposed to be just kind of feeling it out with fingers, or like just what is the best practice in terms of being aware and trying to make sure that you're properly examining the right areas?
So typically I'll tell patients as soon as they get out of the shower, for instance, that they look at the breast. So they're just going to be looking at the breast tissue. Like Dr. Porter said, you really want to look at the actual skin itself. And you can actually lift your arm as well so that you can see that there are changes kind of as you lift your arm, or even if you have a little bit, if you're, have a little bit more breast tissue, to kind of like lift the bottom of the breast so that you're also looking underneath as well. The skin is a really important piece of this, because you want to look if there were any things like signs of redness, any dimpling on the skin or puckering on the skin, any new rashes on the breast tissue, any nipple changes. And so sometimes some people have nipples that stick out and some that stick in, but they should always be consistent over your lifetime. So if it ever seemed like that changed, that could indicate that there's something new that's happening in the breast. In addition to that, when we talk about self-exams, again, we kind of recommend more of breast self-awareness, but if you were going to be doing your self-exam, you can really just kind of like use one hand and sort of kind of just check the tissue. You want to look at it into the armpit, so it almost looks like you have your breast tissue, but it goes into your armpit as well. That is inclusive of just like the skin in under the armpit, but in the front as well. And then the breast tissue in as a whole toward the nipple. Again, we don't necessarily expect you to say, okay, I'm going to go ahead and I'm going to go through in this maneuver or motion that we would do here in the office. But if you were to ever notice, or let's say you hurt yourself, or you like kind of felt something, or if you notice some pain that's not usually there, that should be something that kind of rings an alarm in your mind to say, hey, maybe I should come in and make an appointment to see my gynecologist.
So almost like a teardrop, right? Like
exactly. Yeah.
Okay, that's so helpful. Now, is this the same protocol if a female has had a breast augmentation or implants? Is it the same thing that you would recommend or expect them to do in terms of their breast awareness?
Yeah, absolutely. I think certainly having either an implant there or even scarring from a breast surgery, whether that was an implant or some other sort of procedure, can definitely make that a little bit more challenging. But again, it's a matter of what your normal is. So after a breast exam, kind of noticing again in the mirror on examination what your new normal looks like, what the tissue looks like, so you could recognize any changes. But otherwise, we wouldn't recommend any more frequent or less frequent examination, and the overall thought of just being aware of your own breast tissue would still apply.
So ladies, as I mentioned and confessed earlier, I just turned 40 this year. So I have a mammogram waiting for me. Never had one before, but I think that there's a little bit of a stigma that goes with mammograms. Like you think that your breast is going to be squashed like a pancake or something like that. Can you help me destigmatize it? Walk me through the process of a mammogram so people can maybe get more comfortable with the idea from what they may have heard prior to ever having one.
So Samantha, I think that's a great question, because a lot of people, they don't know what to expect. And basically when you come in for your mammogram, you'll undress from the waist up. You'll get a gown to cover just like you would at the doctor's office. And then you want to make sure that you haven't put any lotions or deodorants on that might have anything that would interfere with the mammogram. And then they place the breast tissue on 2 plates. And they're like plastic plates, and they kind of flatten the breast tissue, and then they take an x-ray. They might have to adjust the breast to get a better image, but they'll do this until they've got the imaging that they need, and then they'll do that on the other breast. And it really doesn't take that long. It's probably less than 15 minutes. You're filling out paperwork longer than you're actually getting the mammogram done. So
yeah, we've all been there. Now, after the mammogram, what happens? I'm anticipating, is it instant image results? Does it go to somebody, like would those images then be sent to you for review? What happens after the actual mammogram typically?
So for a screening mammogram, they're going to send those images to a radiologist, and you're not going to get answers or results right away. But for a diagnostic mammogram where the radiologist is right there, you'll get instant results and images. And you might also have an ultrasound that accompanies that. But the difference between a screening mammogram where you are just screening there's nothing to look at like a mass or an area that's painful or a cyst, those would all be going towards a diagnostic mammogram. Screening mammogram is something that you would usually get a letter in the mail at a different time. Those images don't necessarily go to your original doctor, they just go to the radiologist, but we would get a report for that.
That's great. Now, I've seen different types of screening. Can you help me understand the difference between like a mammogram, a breast ultrasound, and a breast MRI? What are they? Is one screening, one diagnostic? You know, how does that work? What's the difference between those three types of screening?
Okay, I can do this one. So a mammogram is really an X-ray. There are, like Dr. Malone said, there's different types of mammography. So there is screening mammography, which is kind of your routine checkup. It is a screening to look for any abnormalities, whereas a diagnostic is typically a much more focused exam looking at a particular area of concern, whether that be the indication of having a mass or feeling something abnormal, having any new onset breast pain, where the radiologist is going to kind of at their discretion make some much more in-depth evaluation of the tissue or an area of concern. So the difference is that most, so you know, with you turning 40, you're going to be going in for your routine screening mammogram. The radiologist will usually say, okay, everything looks good, you're going to come in for your screening mammogram next year. However, if you came in a few months and said, look, I'm having this weird pain or something that's new, we would send you for a diagnostic mammogram. So those are the two distinctions between the screening and the diagnostic. A breast ultrasound, so when we talk about just a mammogram, that's an X-ray. Ultrasound is a different imaging modality which allows us to see a little bit of soft tissue much better. So it is sometimes recommended in women who are below the age of 40. In some cases, if there's a concern about a cyst, which is a fluid-filled sac, sometimes ultrasound may be the first recommendation for patients in whom they are younger and the breast tissue is actually harder to see through. Ultrasound can also be supplemental to a mammogram. So like Dr. Malone said, in some cases, if you have a diagnostic mammogram where there's an image that needs to be evaluated further, an ultrasound may accompany that mammogram in order to give the radiologist an idea of what is going on in that specific area. When we talk about MRI is magnetic resonance imaging. That is a different imaging modality, which looks, it takes a lot longer of an exam. It is something that is recommended in patients who have a very high risk of breast cancer. So if they have an above the baseline risk, let's say they have a really strong family history or they have some of the risk factors that we've discussed, in some cases MRI is recommended for those patients in addition to screening mammogram once a year. And that's a particular area that would be discussed obviously with your doctor, and your doctor would advise whether or not they feel that you are at increased risk of having breast cancer, and if you were at increased risk above baseline population, an MRI may be recommended.
I think that that's so helpful to understand from a layperson's perspective, all of the three different kinds of screening and how detailed it can be. So thank you so much for explaining that to us. Now, let's say the result comes back and there's something that looks suspicious or there's a lump. Besides somebody freaking out, what do we do next?
Sure. So when we talk about your results coming back from a mammogram, a mammogram result isn't a positive or a negative thing. There's kind of a scale of findings that the radiologist will give almost a score that we use to determine what your risk is, or kind of assess what the findings were on the mammogram. One common finding, especially for women who are just having their first mammogram, who don't have any images that they've seen before, you're kind of new to the radiologist. One common finding is an incomplete study. So one often phone call that we have to make that does cause quite a bit of anxiety to some patients is that the study was incomplete or that we need more images. Like I said, this is very common. This does not necessarily mean there's anything abnormal at all, and sometimes it just means that those two images that we talked about, one image up and down and one image side to side of each breast, isn't sufficient to fully see all of the breast tissue. This is a common finding in women with particularly lumpy breast tissue in general, more dense breast tissue, or sometimes it's just the imaging technique that was used initially didn't give us the clearest picture. So to be thorough and complete, they call you back for one of those more thorough examinations. Again, this is not in any way indicative of an abnormality and should not be a cause for concern. Initially, needing to be called back is very common. Alternatively, if we do get the result that there is truly an abnormality beyond just an incomplete study, based on that abnormality, there are, again, a few different grading techniques that they'll use. Oftentimes, if they have an area of concern on the initial screening, they will ask for the diagnostic imaging, which again is a more thorough mammogram study with the ultrasound combined with that. Based on that, if there's still truly an area of concern, again, the radiologist has several criteria to evaluate those areas. Sometimes they can very clearly say there's an abnormality, but it's not a cancerous abnormality. It's something we can monitor over time, and they may recommend another mammogram of just that particular area in 6 months. Sometimes they may recommend a biopsy or even a surgical consultation. So again, it's not a positive or negative result. There's a gradation of things that we find. And so based on that, there's kind of a range of follow-up depending on what we're seeing that we may recommend. If a biopsy is recommended, oftentimes the biopsy is done again by a radiologist. They use the imaging to find that particular area of concern to do a biopsy, and then go from there. A biopsy takes a piece of the actual breast tissue and sends that to the pathologist for evaluation.
And then, so if something comes back malignant or benign, so can you just for everybody help define the differences? So benign is not bad. Malignant would be considered something that would be cause for concern, correct? Right? Or cancer, should we say non-cancerous or cancerous, or what is that?
Yeah. Mm-hmm.
Okay, so let's talk. So benign, that's fantastic. We will see you next year, right? Or unless there's any other changes, right, for your next exam. But if you do have something that's malignant and you go through the steps and the processes for screens, biopsies, they test the tissue, and let's say, because we know, what is it, 1 in 7 or 1 in 8 women are at risk for being diagnosed with breast cancer. So let's say that it is a malignant result, and then what happens then? I mean, and I know that that's hard to say because there can be varying scales of what is, but what is the next steps for someone that may have a malignant result after going through their screenings and diagnostics?
Samantha, the first thing I do with people is kind of say, I remind people that breast cancer is treatable, because I think that people are so scared. I just bring that up before we start diving into treatment. And then I schedule an appointment with them to see a breast surgeon. The next step is usually some type of surgery to get a full diagnosis and staging of the breast cancer. And oftentimes before that too, you will have to do some more imaging, and all of that is set up with the breast surgeon.
I love that you just emphasized breast cancer is treatable, because I think that as I get older, I'm just getting super paranoid about everything, right? Because all of a sudden I'm at risk for everything. And so to know and emphasize that breast cancer is treatable is really helpful for everybody to try and take that in and digest it if that's the path in life that they're going down. So in terms of local resources or research organizations, do you have any that you refer patients to that may be going down that path that needs some extra support or more information? Or what do you recommend for someone that may need extra support after getting a diagnosis?
So first, at least when even pre-consideration of breast cancer, ACOG, A-C-O-G, is the American College of OBGYN. It's acog.org is the website. They are the kind of overseeing body for our board certification and our board process as OBGYNs. ACOG has excellent patient information and handouts on even like what to expect for mammogram and sort of the things that we've even gone over today, what to do, what not to do, and what to do in terms of follow up on. The American Cancer Society has excellent resources for evidence-based information, but also has some excellent resources, even local. There are local sites and chapters of the American Cancer Society with support groups. And breastcancer.org is also another place that's really great in terms of giving information about up-to-date research. But typically, a breast surgeon would be kind of the one who would formulate this relationship with patients once a breast cancer diagnosis is made, and then kind of creating a follow-up from there. Most of the time, it is a multidisciplinary approach, meaning that you're not necessarily only going to be seeing one doctor. You may see the breast surgeon, you may see an oncologist who's a specialist in cancers who would either help with treatment options or medication management, in some cases, depending on types of breast cancer. So there's definitely a team approach to it, and to understand that you're not alone, that this is, again, a very common, unfortunately, a common cancer. But if you look at even like 5-year survival rates, that there's actually been shown to be like most currently a 5-year survival rate of breast cancer is 90% compared to 1975 where it was 75%. So we've actually made some really good change in terms of some of that is screening, some of that is treatment, and so we try to progress all the time in terms of research, and so a lot of these organizations have been dedicated in doing that. But one of the things that we can do preventatively is just making sure that you're following up with your OBGYN for screening and then understanding what your screening options are.
This has been so helpful. I have to ask, because we've heard about the survivability, that breast cancer is treatable. How close are we getting to a cure? I know we have no crystal ball, but is the research progressing in that way? And what needs to be done to really push it that way? I know that I don't know if that's even a question that can be answered, but are we just looking at ways that we need more funding? What are we looking at in terms of getting close to a cure for breast cancer?
So unfortunately, with breast cancer as well as most types of cancer, it's not a single identifiable thing. Breast cancer is not one thing. There are many, many types of breast cancer. There are many different genetic syndromes that are associated with breast cancer that all have different treatments, different prognoses. So to say we're coming up with a cure for breast cancer is probably not a single cure. There will never be one cure for breast cancer. There will never be one cure for cancer in general. The goal is just to continue to improve our diagnosis, our ability to identify specific genetic mutations in one person's cancer, because everybody's cancer not everybody, most people's cancer is different. So finding treatments specific to the genetic makeup of an individual's cancer is important. So it's more about our ability to individualize the breast cancer treatment rather than to come up with one single cure. So to continue finding new chemotherapy agents, new perhaps new screening options, things like that will help improve our treatment of breast cancer. But again, it's not a single disease that we're talking about here. There's so many types and so many variations in breast cancer, which makes the treatment very, very difficult. So yes, breast cancer supporting funding for breast cancer research is definitely very important, but again, the number one most important thing you can do is maintain a close relationship with your doctor to be able to identify your personal risk, continue your clinical examinations, and follow you throughout your lifetime to help manage anything that were to come up.
I think that that's so important because I feel like there are some campaigns that make it seem like there will be a cure someday. I mean, I hope that there is, but it can be a little bit misleading. So our aim is to try and support research and fund the research that can come up with multiple treatment options so we can make sure that this is a treatable disease and increase survivability, correct? All right.
Absolutely.
So,
and also just, making sure that you're following up for your screenings too, because the earlier a breast cancer is found, the more likely that it will be to be able to be treatable. So that means not waiting too long between exams, making sure that you're kind of staying up to date. It can sometimes get hard. People get busy, or sometimes people just really don't like coming to the doctor, which is why it's so important to have a good relationship with your OBGYN or your primary care doctor, to be able to feel that you can be in a space where you're able to come in if you have a concern, but also so that you make sure that you're seeing someone on a regular basis to ensure that you're kind of assessing your risk at baseline, but also just doing your screening tests routinely.
This is also one other reason why we really appreciate organizations like yours and different groups trying to get this message out there, trying to, as we mentioned before, destigmatize the whole idea of breast cancer screening. We all unfortunately have or will know someone who's been affected by breast cancer. So the more we can have these open discussions and make everyone aware of the importance of breast cancer screening, the better chance we have at taking care of each other.
I love this so much. Now, can we talk about right now, getting to the doctor in a pandemic is a little scary, it's a little tough, but I think that you emphasize diligence. Now, how is it with normal? We don't want to deter any of our watchers, viewers from getting to the doctor, even in a pandemic, right? So how can we be diligent in keeping in contact with our doctors? Have things changed right now in the clinic? What can we expect, or what should we expect, so we can be diligent about our routine examinations in the pandemic? So let us know how things look right now with patients that are coming to see you for routine or annual care.
So we still recommend your annual care. It's a little bit different because we're all wearing a mask, as you can see. We do take your temperature when you come in the front door, and we have you wash your hands. We try to stay 6 feet apart, and if not, then we're all wearing a mask. It's really important to keep up with your annual care and just keeping good care of yourself, even though we are in a pandemic, because you don't want to let things fall by the wayside and then have to come in when it's last minute.
I feel like I just went to the doctor, and especially the pediatrician, with my daughter. I felt like, because everybody was so careful, that I don't want to say it never was a safer time to go to the doctor's office, but everybody's being so careful and diligent with sanitation and masks and everything, that we don't want people to be scared to go to the doctor right now, right?
Absolutely.
Perfect.
And a lot of offices, including our office here at West Suburban Women's Health, are utilizing telemedicine. So for some conditions, which can often be determined whether or not that's appropriate with your particular doctor's office, but there are a lot of things that we can also do just like this. So we're doing some telemedicine visits over video. Oftentimes a breast concern would not be appropriate for a video visit. That should warrant an exam and things like that. But there are a lot of concerns that you can address in a remote format such as this with your doctor. So there are definitely accommodations being made at all types of doctor's visits, and certainly the same type of safety precautions are being done for routine screening, mammograms and things like that. So we do not want to let any kind of screening, whether that's mammogram or otherwise, be neglected, because that, as we know, can lead to other serious health implications.
Doctors Porter and Rodriguez and Malone, thank you so much for your time today and taking time out of your busy schedules to speak with us on such an important topic. Now, for any of our viewers out there that are looking to come in as new patients, what's the best way to schedule an appointment with you?
Just give our office a call, and one of the receptionists can get you scheduled. We're open from 8 a.m. to 7 p.m. Monday through Thursday, and then Fridays we're open from 8 a.m. to 3 p.m.
The three of us are all accepting new patients and would be happy to take care of any of the members of your group or anybody else seeking care. Our office can be reached at 630-654-2229 or online at wswomenshealth.com, and we can provide you the information as well.
Well, thank you, ladies, very much for your time. This has been so informative, and if we could make a difference for anybody out there listening, then this is all well worth it. But I've also enjoyed it and thought that it was super informative as well. So thank you for all that you do. And we are so lucky to have West Suburban Women's Health as community partners with the Downers Grove Junior Women's Club. So thank you, ladies.
Thanks for having us.
Thank you.